Thank you for coming to Managing Respiratory Infection. This session will be presented by Dr. Azar and Dr. Rhinitis. Dr. Azar serves as the Clinical Director, Division of Allergy and Clinical Immunology, and Associate Professor of Medicine at Johns Hopkins University School of Medicine. And then Dr. Rhinitis is the Section Chief of Allergy and Clinical Immunology Division and Professor of Pediatric Medicine, Microbiology, and Immunology at the Medical College of Wisconsin, and is a member of the IDF Physicians Advisory Committee. Please join me in welcoming these two gentlemen.
Good afternoon. Can you all hear me well? All the way in the back? Yes? Okay, great. Thank you so much for inviting me to be part of this. I have to thank the IDF and every single one of its members for the excellent work that they do in spreading all the knowledge about immunodeficiencies. It's an incredible work that they do all over the country and internationally as well. Just because this is right hot off the press, I want to share with you that at our institutions at Hopkins, we got on the front page of the Hopkins magazine, which goes to tens of thousands of people, so we're happy that we're doing our part in contributing to spreading more awareness about primary immunodeficiencies, and especially when it comes to adults. Usually people talk about diabetes and heart disease, but we're thrilled that this has become a topic that we're talking more about. I want to keep this low-key, especially that it's after lunch, and talk about sinus disease. Try to tell you the story about sinusitis. How many of you in this room have had sinusitis? Almost everybody. And I just met Scott over lunch, who told me he's had 200 sinus infections before his CVID diagnosis was made. 1 in 8 people every year get a sinus infection, so it's very common. And in fact, this is one of the most common reasons for people to get prescribed antibiotics by their primary care doc. 11% of all antibiotic-related visits are because of sinusitis. So it's quite common. And not only is it common, but you can really feel miserable when you have a sinus infection. Your quality of life is significantly affected. You don't feel well. It's estimated that on average a person has 1 to 2 days lost from work per year. And for those with chronic recalcitrant sinusitis, up to 18 days of lost work per year. So the healthcare cost of this is pretty huge. It's estimated to be about $9 billion a year in direct healthcare costs, and a total of $13 billion to include lost work and productivity. So it is definitely a big deal. So what is sinusitis? What we're talking about? As you know very well, itis, that we like to use a lot, anything that ends with itis is inflammation. Now this inflammation is very frequently due to infection, but it could be due to something else as well. Now rhinitis is inflammation of the nasal cavity. It's inflammation of the mucosa or the linings of the inside of the nose. Sinusitis is inflammation of 1 or more of the sinuses. To make it even more complicated, there's rhinosinusitis. Now, what rhinosinusitis is actually is the new term for sinusitis. So if you look at all the medical journals and the medical field, we don't call it sinusitis anymore. We call it rhinosinusitis. The reason is to stress the importance of the inflammation that's not only in the sinuses, but also in the nasal cavity. That's important in terms of how sinusitis occurs and how we treat sinusitis as well. So that's the new medical term, rhinosinusitis. In this talk, I'll be using both sinusitis and rhinosinusitis interchangeably. So what are the sinuses? These are air-filled cavities inside our head. Why do we have them? There's a lot of reasons. One, they produce mucus, and that mucus, it goes inside the nose, it lines up our mucosa, it helps clear the air, filter it. There's a lot of other theories, including it makes our head lighter, so we're standing upright, or it helps with the resonance of our voice. The problem is they're cavities full of air sitting in our head, and it's easy for them to get infected. That's why Dr. Cunningham-Rundle earlier showed that the most common infection in CVID patients is sinus infections. Now, these sinuses also, I'm going to try to use this pointer on this side. So sinuses are located here, and there's 4 sets of them. There's frontal above the eyes, maxillary under the eyes, ethmoids between the eyes, and sphenoid, which is right there. It's just kind of behind the eyes. And these sinuses drain into very little tiny openings inside the nose. This is the nasal cavity here. And these guys drain inside these tiny little holes. And when they drain here, the drainage can go in the front. That's why a lot of people have drainage. In the front, you blow your nose a lot. And the drainage can go in the back of the throat as well, or postnasal drainage. But as you can see, it's not a very easy mechanism to be able to clear these secretions from the sinuses. So what happens here, you have the mucosa that needs to push all the fluids up there and push it out of the sinus so it goes inside the nose and it clears out. The way this happens is via tiny little fibers that we call cilia. These are the cells in the nose. These are little, very tiny little microscopic fibers, and this is the mucus. These cilia are constantly beating all the time to clear this mucus up and get it out of the sinus. It has a kind of an uphill work to do to push the mucus out and out of the sinus. These are some of these cilia that are beating, and they beat at 700 beats a minute, pretty fast. This is important for a couple of reasons. One, when you talk about sinus surgery, having a lot of invasive and multiple sinus surgeries may not be a very good idea because you don't want to mess with these cilia. It's good to have them working normally and clearing up the mucus. And there's a very rare disease where people are born without these cilia, and if you're born without them, then you're at a big risk for sinus infections. So what happens if the nose gets obstructed and you can no longer clear those secretions very well? They will build up inside your sinuses and they will cause a sinus infection. Make sense? So rhinitis is inflammation inside the nose. Okay? It's inflammation of the mucosa inside the nose. It can be caused by infections. It can be caused by allergies or irritants as well. The main symptoms of rhinitis is sneezing, difficulty breathing through the nose, and nasal discharge. In general, a clear nasal discharge is usually not infected, but when it gets thick and green, it indicates that there may be an infection. This is the rhinitis, inflammation inside the nose, which, as we said, accompanies sinusitis. Now, sinusitis, the main symptoms of that are a discolored nasal discharge, facial pain, pressure, fullness, pain around the eyes and the upper jaw, and many times people have a reduced or absent sense of smell. Some other symptoms include fever, but does not always happen. So if you don't have a fever, it doesn't mean you don't have a sinus infection. People feel fatigued, malaise, decreased appetite, and all of these will resolve when the sinus infection is improved. Sometimes there's ear pain and pressure as well because there's connection to the ear on the back. You can get a cough, bad breath. And sinusitis symptoms, they tend to be worse in the morning. This is when you're laying down all night, so all the mucus and they have kind of set down in the sinuses. They tend to be worse when you first wake up in the morning. Now, how about the duration of sinus infection? We call an acute sinus infection acute that's less than 4 weeks. A subacute is between 4 and 12 weeks, and chronic sinusitis is beyond 12 weeks, and many times it's years and years of inflammation in the sinuses. Now, a lot of people with CVID or immunodeficiency, they have recurrent acute sinusitis. Recurrent acute is defined as having multiple, 4 or more episodes of acute sinusitis per year. So if you get an acute sinusitis, you get a lot of inflammation, then gets better, goes down, but then you get another. So you get back to normal in between, but then you get an infection later on. One of the main questions is what is causing the sinus infection? Is it a virus or a bacteria? And that is not an easy question to answer. If you really want to find the answer, then you do this. That's what I do in my office all the time. No. So you will have to open up the sinus, go on the inside, take a culture, and confirm whether there's bacteria that's sitting inside the sinus. You do not want to do that. Nobody wants to do that. So many times we rely on some other factors on the clinical end and by exam and so on to be able to help us decide whether it's a viral or a bacterial infection. A viral infection is the most common cause of sinus infections and tends to go away without antibiotics. A bacterial infection is one that will require antibiotics. Now, there's a good alternative to opening up your face and your sinuses, which is having this procedure, having a scope done. That's why I tell people who have recurrent sinus infections to have a good relationship with an ENT physician, ear, nose, and throat, or an allergist who does these procedures. It's a minor procedure, takes a few minutes, a scope placed inside the nose, and just under local anesthesia. And if they're able to find that pus here or mucus that's coming out of the holes inside the nose, they can culture that, and that would be a good representation as to what's going on in the sinus. So it's a very useful test. And many times, if it's difficult to treat a sinus infection, it's useful to be able to get that culture to guide you and help your docs decide how to treat it. So in general, viral infections, the main symptoms are a nasal discharge. It's clear and watery. The discharge can become thick and eventually will resolve without even needing antibiotics. A fever is unusual, and if it does occur, it occurs in the first couple of days. The fever and all the constitutional symptoms, they tend to resolve in about 1 to 2 days, and then the respiratory symptoms will stay for about 5 to 10 days. That's the usual course of a viral infection. So if you look at what it looks like, this is initially the fever that lasts for a couple of days, then goes away. And you have all the other respiratory symptoms of a sinus infection. They peak about day 3, 4, 5 to 6 days, and then they slowly start to get better, the sinuses start to drain, and things improve. However, if after about 5 to 6 days, you're not getting better, or you start to get better, and then suddenly things start to get worse again, this is very suggestive that a bacteria found its way up to your sinuses and now is causing problems up there. And that suggests a bacterial infection. So bacterial infections are likely if the symptoms are persistent, worsening, not improving, if the symptoms are severe, like a high-grade fever, if there's a pus that continues to drain for more than 3 to 4 consecutive days, and that double sickening I told you about, where people start to get better initially, but then they start to get worse again. All of these are signs that you may have a bacterial infection. The most common bacteria that will cause these problems, I'm sure you've heard of all of them. These are what's called the encapsulated bacteria. These are bacteria that have a thick sugar capsule around it. Our antibodies are the best way to defend us against those bacteria. So if you have CVID or low antibodies, you cannot fight off these bacteria. And these are Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. But I always remind people with immune deficiency, it's the rule of the unusual. As with immune deficiency, you can have unusual organisms that are not the usual common ones. You can have unusual frequency of infections, like Scott with 200 sinus infections, unusual severity, unusual duration where it lasts longer, and complications from sinus infection that may not occur in somebody with a normal immune system. The main complication from a sinus infection is the repeated episodes of sinus infections can lead to chronic sinusitis or chronic inflammation in the sinus. And that chronic inflammation can lead to damage to the sinus mucosa and so on. There are some other complications, but these are really uncommon. Osteomyelitis, when you get a bone infection, when infection spreads from the sinus inside the bone, people get fever, swelling of the sinuses, though usually the blood count will show like very high white cell count. A brain abscess is when infection really spreads into the brain. Usually presents as headache, vomiting, and neurological signs like weakness or numbness of one side of your body. And the bacterial meningitis, which is infection around the brain and the fluid around the brain. That's where you get fever, stiff neck, headache, photophobia, which is really sensitive to the light, vomiting, and seizures. So the ones in red are really danger signals when you develop a sinus infection. Now, how do we diagnose sinus infections? The best test is a CT scan. Do not do a regular X-ray, not very useful, or MRI. The best test is a CT scan. It's easy to do. Most of the time you can get it done within maybe a day or two. It takes only a few minutes. And what we look for is a lot of inflammation in the sinuses. This is a patient before and after they were treated. So the sinuses were full right here, and then they cleared up. One of the signs we look for on a CT scan is called an air fluid level. This, when you lay down on your back to get the CT scan, it shows that there's a lot of fluid that's layering and causing a leveling between the fluid right here, which is the infection, and the air in the sinus. That's another indication for us that there's a fluid in the sinus. So best test to do, anyone with recurrent sinus infections or chronic sinusitis. In fact, you cannot diagnose chronic sinusitis without doing the CT scan and finding this type of inflammation on the CT scan. So anyone with recurrent sinus infections, chronic sinus infections, should have a CT scan to evaluate what's going on in the sinuses and confirm that this is what's going on. One of the reasons is not every facial pain and pressure is a sinus infection. People with immunodeficiency or CVID can also get migraine headaches or temporomandibular joint pain, dental pain, neuralgic pain, temporal arteritis, which is inflammation in some of the vessels in the frontal area, or neoplastic conditions as well. So the face has a lot of layers outside the sinuses. There's nerves and muscles and subcutaneous tissue, and a lot of these can be affected. So you can have some of these going on. It doesn't always mean a sinus infection. What are the risk factors to get acute sinusitis? Of course, we're talking about immunodeficiency. That's why we're here. If you do not have a good immune system, you cannot fight off these infections, and that's a main risk factor. Allergies, something else to think about. We'll talk about this in a second. Smoking, we just talked about how delicate this mucosa is, and if you smoke, you're going to irritate it more and cause it not to function well. So it's very important not to irritate this mucosa and those linings any further by avoiding smoking. So avoid smoking. Older age, do not get older. Swimming, dental disease, and change in pressure with air travel or deep sea diving. And the next speaker, Dr. Rhinitis, will tell you about how not to get older. So what's the role of allergies? Allergies, when we become sensitive to things in the environment that are called allergens, normally they're inert, they don't cause problems for most people, but those of us who are allergic, which is the general population is about maybe a third have allergies. People with immune deficiency also can get allergies. Allergies can occur to things like dust mites, molds, pet dander, pollens like trees, grasses, and weeds. The allergic rhinitis, now that you understand very well what rhinitis is, allergic rhinitis is inflammation in the nose caused by allergies. This is what's called hay fever, which is a big misnomer because it has nothing to do with hay and does not cause fever. The symptoms are itchy, stuffy, runny nose, sneezing. The eyes can be affected as well with watery, red, and itchy eyes, which are called allergic conjunctivitis. Allergies can be tested very easily via a skin test that takes maybe half an hour or so, and it tells you immediately what and what not you're allergic to. Or sometimes you can get a blood test done as well. So it's one of the factors to look for and to try to control if you have recurrent sinus infections. Now, how do we treat allergies? This is one option. All it takes is a trip to the Home Depot. Very effective. But the main treatment is avoid what you're allergic to when possible, like dust mites, molds, and pets. Non-sedating antihistamines like cetirizine, fexofenadine, loratadine, nasal steroid spray is very important, and allergy shots or immunotherapy that over time can help significantly reduce and eventually cure the allergies. Now, how do we treat sinusitis? The goal is to improve the symptoms and to reduce potential complications from sinus infections. So prevention and early intervention are key. A healthy lifestyle is always great. Adequate rest, nutrition, exercise, especially when you do have a sinus infection, you gotta take a break, rest, and hydrate well and let it heal. Sinus infections, of course, can be more difficult to treat in somebody with PI and can take longer duration to treat in somebody with PI. The main treatments include antibiotics, nasal saline rinses, and nasal steroid sprays. Let me start with the saline rinses. How many of you perform saline rinses? I don't know why the others do not, but, but it's one of the most effective things that you can do. They're very simple. They're scary if you do them the first time, but almost maybe 99% of my patients who started doing them swear by them like a week or two later. You can use a squirting bottle, an Etipot, or fancy electric battery-operated machine to irrigate. You know, some people like to use that. Make sure that you use distilled water or filtered water or boiled water, but not tap water. You don't want to introduce bacteria or organisms inside your sinuses, and you mix it with salt solution that you can make at home or you can buy packets. But it is very important and effective therapy to clear up all the junk in the sinuses and prevent things from accumulating and causing obstruction. Okay, so really key. The other thing are nasal sprays or nasal steroid sprays. And this is a nasal spray, and this is what you do when you use a nasal spray. You put it up your nose, and it sprays that steroid up your nose. And that very nice graph there is completely wrong, because that's not how it should be done. And almost everybody I've seen who uses nasal sprays uses it the wrong way. And it sometimes makes a big difference just to be able to use it the right way. It's very normal for us to stick the nasal spray up this way, but what you want to do, you want to spray it toward the back where the inflammation is, where the mucosa is, where the openings of the sinuses are. So that makes a big difference. I've had people have significant improvement just by doing that. So these are a couple of different ways. Don't use it upright, but use it toward the back, as if you're spraying toward your ears. Antibiotics, first choice antibiotics are amoxicillin or augmentin. Others are doxycycline, some cephalosporins in combination with clindamycin. Recently, we no longer recommend some of what we used to treat with sinus infections, like azithromycin, which is Z-Pak, Biaxin, or sulfa-Bactrim. They may not be as effective for the bacteria that cause sinus infections. Now, if these don't help, after a few days, after 3 to 5 days, you may need to switch to maybe a stronger or different kind of antibiotic, or you need to reevaluate for complications if there's something else that happened other than just a plain sinusitis. Given that the amoxicillin and the augmentin are first choice and really important antibiotics, I'm going to ask you this question. How many of you are allergic to penicillin? Okay, 7.2%. This is really important because 10% at least of the US population have a listed penicillin allergy. 10%. 1 in 10 people. But when you test for penicillin allergy, and now we have an incredibly useful and effective test for penicillin allergy. When you test for it, less than 9 out of 10 people who believe they have a penicillin allergy are no longer allergic. This is for a lot of reasons. About 80% of people outgrow their penicillin allergy 10 years later. So for those of you who have a penicillin allergy, it is very useful to get that tested because there's a very good chance that you may not be allergic anymore. Some other measures to treat sinus infection is, of course, fluids and rest, analgesics for pain, and sometimes elevating the head and shoulders at night to reduce that cough and postnasal drainage. There's a plethora of other things that are used for sinus infections. It's not very clear whether they help or not. If it helps you, that's fine to use them. These include topical or oral decongestants and expectorants. You do not want to use these chronically, but only in the setting of an acute sinus infection. Now, chronic sinusitis is when this becomes a chronic inflammation in the sinuses, usually for a very long time, months and years. Sometimes it cannot be completely cured, but it can be controlled and the complications can be reduced. And the goal of treating it is to control the mucosal inflammation and swelling, maintain good ventilation for the sinuses and good drainage, reduce the acute exacerbations, and treat the bacteria as they show up. And the bacteria in chronic sinusitis may be a little bit different than those encapsulated ones I talked about earlier. You may have things like staph, Pseudomonas, or anaerobes that can develop in the sinus, so it's important to treat those as well when needed. Other treatment includes nasal steroid sprays, and there's a lot of them, and the reason I took this picture is, this is from, I believe, Costco. These are 5 bottles of nasal sprays that are good for 5 months, and I believe the last time I checked, they were $22.30. So it's like $4 or $5 a month for a nasal spray. So even if you're paying for this out of pocket, totally worth it. Prophylactic antibiotics can sometimes be used, or preventive antibiotics that you take on a regular basis to prevent infections. Of course, immunoglobulin replacement therapy and adjustment in the doses for that, and treatment of the underlying immunodeficiency disorder, whether this is something that involves gene therapy or stem cell therapy or so on. Now remember that there are some other things that can cause chronic sinusitis. This includes nasal polyps. This big shiny thing should not be there. That's a big nasal polyp. So you should be checked for that as well, because treatment for that may be very different than how we treat the regular chronic sinus inflammation. There's new drugs or biologics that can be used for those conditions. Cystic fibrosis, a common autosomal recessive disease that can cause problems with the sinuses and the lungs. I mentioned earlier if you're born without these cilia, it's called the ciliary dyskinesia. So the cilia that are beating can no longer function. That's another cause. Vasculitis is a serious condition that involves inflammation in the vessels. People get problems with their sinuses, but with multiple other organs of the body as well. And a couple of these are what we used to call Wagner's, or granulomatosis with polyangiitis, and Churg-Strauss, or eosinophilic granulomatosis with polyangiitis. How about surgery? One thing about surgery alone will not be effective to treat sinus disease. Even if you require surgery, it must be accompanied by chronic medical management as well. And the surgery should be a minimal surgery. Remember, to preserve all the mucosa that we talked about. These are examples of what's called a functional endoscopic sinus surgery. It's function because you're not going in and cleaning all the sinuses. You just go in and with very tiny probe try to open up a little bit these sinuses, the opening, so they can drain better. The indications for surgery are usually to restore the sinus ventilation. It's very obstructed. If there's a failure of improvement of intense medical therapy, and if uncommonly the disease spreads outside the sinuses, it starts to invade the bones or so on. So my take-home points from this is, one, sinusitis is very common. You all know it. Inflammation involves both the nose and the sinuses, or rhinosinusitis. I think I mentioned this several times. It's really important. Saline therapy, nasal therapy with nasal saline rinses and nasal steroids is very essential, and complications can occur, though uncommon. This is our center I think we're somewhere here on the 2nd floor, and thank you very much for listening.
Do I have to do anything to get? Well, good afternoon. I love the IDF conference, all the conferences that I attend. This is my favorite one. I get to talk to the best people in the world, my patients and patients like that, the most motivated bunch of people you'll ever meet to really want to get better and, you know, improve outcomes. And it's just great to hear the story. I'm always honored that I'm invited to come. This talk I've switched around a little. Over the years, I've sort of found that I was speaking over people instead of with them. And then in addition, the other thing is the lung is so commonly involved in immune deficiency. Just to talk about infection, I thought was sort of a mistake. So I'm going to broaden it. I'm going to talk about some of the testing we do in lung function, CT scans, and then a little bit about what we're doing in terms of research on a lung condition that occurs in common variable. So as you know, the lung is almost always involved in severe primary immune deficiencies. And it's really important that we detect the disease early, because if we detect it early, we might be able to intervene and prevent some of the long-term damage. So what I'm going to first talk about are some common methods to detect lung disease. And so this is the standard. The chest x-ray. It's sort of like the sinus x-ray that Dr. Azar was talking about. It's great, it's cheap, it's quick, but it misses a whole bunch of stuff. And really, when I started out, the chest x-ray and pulmonary functions were the screen for lung disease. If that's all you've ever gotten, that's a mistake in general, because it isn't a good screen. It will pick up big things but miss a lot. This is the best screen for anatomic problems in the lung, and this is the CT of the chest. And what I did, I don't know if the people in the back can see it, is I blew up, to illustrate the fine detail that you can see. You can actually see the bronchi, or the air tubes that go to the alveoli. And because we look at an adjacent blood vessel, we can determine actually if the bronchi are normal size or enlarged. Normally, the blood vessel in the adjacent bronchi is about equal, but I'm going to show you an example in bronchiectasis where that changes. So the CT provides a lot more detail. And it is the best single test that you can use to detect lung disease. It's also the best test to follow response, in particular if you have a chronic lung problem. I'm not saying everyone that has a pneumonia should get CT scans. That's really over the top. But it is an important modality to follow chronic lung disease over time. The downside, more radiation than a chest x-ray. The good news is, and this is all over the country, the CTs that we do at Medical College of Wisconsin have about 20% of the radiation that we used to use when I went there 13 or 14 years ago. So we're really cutting down on the radiation so that, if you're going to need this over a lifetime, you can be safely done. And then more recently, there's been some studies on other methods to look at the lung, like the MRI. And I would still say that's still in the research stage. The next thing that everyone should have at one point in time are pulmonary function tests, or PFTs. So the chest, the chest x-ray looks at the anatomy. The pulmonary function tests say, how does the lung work? And I view these as hand in hand. One complements the other. And so I think pulmonary functions are an essential test that everyone should have. And in particular, what we do is what's called complete pulmonary functions, and that's where you go into a body box, the clear plexiglass, and it also measures your ability to extract oxygen, through your lungs. So what do we measure? You probably have had these tests and no one's bothered telling you what is it that we're measuring. So spirometry, which is typically what we get in a clinical setting, you come into the clinic and you get spirometry. The first thing we do is we measure what's called an FEV1. You take a big breath in and you blow out as hard and as fast as you can. The amount of air that comes out in that first second is the FEV1. The amount of air that you blow out when you think you're going to pass out at the very end and they're screaming blow, 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 and you have no air in your lungs, that's the forced vital capacity. I swear I almost pass out every time I try to do that. And again, complete PFTs are spirometry, and they also measure lung volumes and the ability to extract oxygen. So complete PFTs In our center, we do those on our common variable patients about every year, every other year. So how do we classify lung disease? How do you ferret out all the different kinds? Well, if it's a chronic condition, we talk about obstructive and restrictive lung disease. In obstructive lung disease, like asthma or COPD or bronchiolitis obliterans, the biggest problem is getting air out, okay? So what happens is when you're blowing, that first second, you just can't get it out. So that number goes down, but eventually you can get it out. You'll blow, 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 blow. It'll be more protracted, and the FVC, or the total air, will be pretty normal. And so we have a ratio. Everyone uses this, FEV1 over FVC ratio. If you're a normal adult, it should be over 70%. If you're a kid, over 80%. And if it's low, that indicates an obstructive lung disease. Why is that important? Because the obstructive lung diseases are different than the restrictive lung diseases. The cause of it and the treatment is different in the course. So knowing if you have normal lungs, obstructed or restricted, and some people have a bit of both, and that's called mixed. Now, restrictive lung disease is something that we're interested in from a research standpoint. And this is where the lungs stiffen up. Frequently, there's a lot of fibrosis or scarring in the lung. And when you have scarring in the lung can't expand like normal. Therefore, because it can't expand like normal, both of those numbers go down. The FEV1 goes down because it can't get that big, that big blow. And then because it's stiff, it doesn't expand as much. That is reduced as well. So your ratio actually stays normal, even though your lung function can be really, really bad. And the biggest cause of this, in particular in common variable, is interstitial lung disease. So right now, rather than try to review all the immune deficiencies and the various manifestations, I'm just going to generally talk about antibody deficiency, but I am happy to talk afterwards if you have questions specific to your immune deficiency. First, I'm going to talk about, pneumonias and PID, and why pneumonias, now with gamma globulin, replacement, and we have so many excellent forms, we don't see a lot of lung infections. We see a ton of sinus disease because, unfortunately, gamma globulin, fortunately, does a great job to prevent pneumonias, but not as good in sinus disease. And people are probably shaking their head, yeah, I get it, because I was started on gamma globulin, I quit getting pneumonias, but I continue to have problems with sinus disease. Now, pneumonias in PID will frequently require antimicrobials that are for a longer duration. You can have unusual bugs, and the doctors must look for these unusual bugs. The biggest mistake that doctors do, and that's why I want you to know about it, is they'll take antibody tests to diagnose a lung infection. Well, you're on IVIG or you're on sub-Q. You're measuring the antibodies that you're getting by vein or in your subcutaneous fat. Or if you don't have the diagnosis of CVID or XLA or whatever it is, you can't make antibodies. So it's a totally worthless test. And so if your doctor says, I'm going to draw some blood and look at your antibodies and see if you have an infection, say, hold on one second. I have a quick question about that. You have to make the diagnosis in terms of the specific organism, either by culture or by PCR. So, when we talk about pneumonias, and pneumonia just means an infection of the lung, there are normal pneumonias, and then there are what we call complicated pneumonias. If I see an adult that had a complicated pneumonia and doesn't have anything else going on, I'm thinking about a primary immune deficiency. So this was a 4-year-old, saw in our clinic, a brother died of infection at age 3, and lo and behold, when we get a CT scan, that abnormality that we saw was an empyema. In an empyema, all that means is it's a collection of pus between the chest wall and the lung itself. So it starts out with an infection in the lung, and then it spreads, and then you get a collection of pus. That's an empyema. The other thing that you probably heard about is an abscess, and that is just in the lung parenchyma itself. It's a walled-off collection of pus in the lung. Now, why do I care about this? Because if you have either of those, it's going to change how we treat your lung infection. And furthermore, if you or your family member or have a friend that all of a sudden ends up with a lung abscess or an empyema, you should be saying, hey, you know what, you should see a clinical immunologist. They should at least screen you for immune deficiency. So I want to switch gears a little bit and talk about common variable. I mean, it is the most common immune deficiency that we see. And it's one I've spent my entire career taking care of patients with. And usually people present with recurrent infections. Recurrent respiratory tract infections are the most common. And they have all, with CVID, you must have a low IgG, but you should also have either a low IgA or a low IgM. And recently, with some collaborators at the University of Virginia and elsewhere, we found out that the IgE is also low in CVID, and in fact, most people with CVID can't have positive skin tests or don't have what we consider true allergy, like hay fever. They don't have, we tested a bunch of patients that thought they had penicillin allergy. They didn't, because they can't make IgE anymore. In fact, IgE is more commonly low than IgA, which previously people thought was the one that was the most common. So we always measure the IgE when we're evaluating patients for antibody deficiency. So with CVID, you have a low G, you have other isotypes that are involved, and you don't make specific antibodies. And who knows what the incidence is? I can tell you this is a made-up number because there is no good data, because most people, the diagnosis of CVID is still delayed. So it's a 30-year-old male who comes in, he has a cough, he has a fever, and get a chest x-ray, and there's a little bit of ditzel down there. Not much. So I want to talk about a mistake that's commonly done in treating pneumonias, in particular with CVID and antibody deficiency. As we heard from Dr. Azar, the most common bug for sinus disease are encapsulated organisms. That's still common in CVID. But what most people don't realize is there's what we call atypical bacterial infections, Mycoplasma and Ureaplasma, which are extraordinarily common in CVID. And I never treat a patient with pneumonia and CVID without an antibiotic that covers this. Most antibiotics, like the penicillins, do not cover Mycoplasma and Ureaplasma. When, in my former days, when I was at National Jewish and the University of Colorado, we randomly cultured, I don't know, it was like 15, 20 CVID patients, just got sputum cultures. They were all colonized with Mycoplasma. It is incredibly common. So, if you get a pneumonia and you're put on Augmentin and you don't get better, this is a good reason why. This is an example of a 35-year-old female we saw. We got a chest x-ray and I wasn't all that impressed. This is what we saw in the CT scan. It's like, holy moly, you know? I mean, it's hard to believe what you miss on a chest x-ray. So next I want to get away from infections and talk a little bit more about the complications of CVID and immune deficiency chronic lung disease. And this was an old study that I did when I was at National Jewish, and we just CT'd everyone. And we know that bronchiectasis and interstitial lung disease are the most common problems, chronic problems, lung problems in CVID. And I'm going to talk a little bit about those, what it means to have bronchiectasis and interstitial lung disease. So again, this was a 24-year-old male, had a normal chest x-ray, normal spiro. It used to be we didn't screen these kids with anything else. 24, I know, he's not a kid, but to me he is. Anyway, and this was the CT. And it's like, so if you have common variable and you haven't had a CT scan, I urge you to talk to your doctor about that. And more recently was a study where they basically took a whole bunch of patients in their clinical practice, and they did chest x-rays and PFTs before, and 6% had either bronchiectasis or interstitial lung disease. Then they CT'd them, 60% had bronchiectasis, 30% had interstitial lung disease. I keep repeating myself because I think a message needs to get out there that if you see a patient, or if you know someone that has CVID and they haven't had a lung CT, screening CT, they need to get one. So bronchiectasis, what is it? Bronchiectasis is an abnormal dilatation of the bronchi. Typically, it's because of repeated infections. When you have repeated infections in white blood cells in the lung, they contain enzymes that dissolve proteins and other things, and they chronically damage the airways. And those airways become ectatic or widening over repeated infections. Now, if we catch bronchiectasis early, it's treatable. You can treat it by just preventing infection. But if it gets too bad, it becomes irreversible, and that's a problem, because if you have widening of the airways without those cilia that we heard about, then that part of the lung tends to get reinfected. So and by the way, bronchiectasis is an obstructive lung disease. So when we take your spirometry, that's what we'll see. How do we treat it? We diagnose early. We know that if you have significant bronchiectasis, you're going to require a higher dose of gamma globulin to be infection-free. We also, more importantly, institute measures that increase your ability to get rid of the sputum. And that typically is with an a cappella or a flutter valve, or in severe cases, a vest. Prophylactic antibiotics should be used in severe bronchiectasis. They reduce infection. And this illustrates a normal blood vessel in a bronchi. This illustrates what happens when the bronchi get dilated. And this is what happens when doctors ignore patients and they think all obstructive lung disease is asthma. This was a bad case of bronchiectasis. So, bronchiectasis, common, we need to treat it. Next, I'm briefly going to talk about interstitial lung disease. What is it? Interstitial lung disease is when you have fibrosis or inflammation between the alveoli and the blood vessel. And that prevents the uptake of oxygen. Over a long period of time, it can cause scarring. And there's a particular lung disease that occurs in CVID called granulomatous and lymphocytic interstitial lung disease, which is what we study at our institution. So this just illustrates normal lung, the fine alveoli under the microscope. You can see in the upper panels the normal CT, and this is what happens when you get interstitial lung disease. We showed way back in 2004, this is a significant cause of morbidity and potentially mortality in CVID. It is not responsive to steroids, and we've sort of started using Rituxan and azathioprine to treat this. And, you know, what the optimal mode of treatment is not clear, but I'll show you we've had some great success using this combination. So our initial study was about 6 years ago on a small number of patients, and we showed that if you use this to treat the interstitial lung disease, the lung function improves and the CTs get clear. And we are in the process of writing up a much larger study. So if any of my patients are out here, 39 patients with biopsy-proven GLILD, and where we had a scoring system where radiologists scored how bad the lung disease was. We saw 90% of our patients improved. And the pulmonary function improved in 50%. 25% relapse, we give 18 months of chemotherapy and then we stop. We've had patients that are going on 10 years that have not been retreated. This is an example of what it looks like before and after. Here's another example before and after treatment. Some of these patients have huge spleens, so you can see on the left, or my left, a huge spleen that decreases with therapy. And so we really think that this is a great way to treat the lung disease. And interestingly enough, all the patients that we've treated, we've sequenced their genome and found genetic causes that cause the CVID, but it doesn't seem to matter. Regardless of the genetic cause, they get better. So I want to stop there, and I want to thank all of our patients that enrolled in the study from all over. We had patients from Alaska to Florida to Texas come to Wisconsin, and I'm really grateful that they came to our institution for this study. And I'll just summarize to say that the lung is commonly affected in primary immune deficiencies. The screening tests initially should be a chest x-ray, PFTs, and a CT scan. You should be monitored periodically for silent lung infection. Some PIDs have unique problems due to the immune deficiency, and make sure your doctor is familiar with these. And now, thanks, and we'll take questions up here now.
So thank you all for coming. We started late, so we're ending a little late, but there is another session in here in 15 minutes. So therefore, we're going to give each presenter about 5 minutes to answer questions. If they don't answer your specific question, we apologize in advance, but you are more than welcome. If you see them afterwards, you can ask them or have a discussion with your primary care provider. Thank you so much for coming, and please do not forget to fill out your evaluations. While they're deciding which questions to answer, let's give them a big round of applause and as a thank you for their wonderful presentations.
All right, so I have a question. How much immunoglobulin should you be on if you have bronchiectasis? Great question. There's a little longer answer. The bottom line is we increase the dose of gamma globulin to prevent pneumonia until you don't have pneumonias. Now, in some instances, you just can't go high enough. And under those circumstances, I think it's important that your doctor fit you for a vest, that you have other measures to try to prevent the buildup of mucus in the part of the lung where you have bronchiectasis. So higher dose of gamma globulin and preventive measures and prophylactic antibiotics. There's never going to be there aren't great studies, although I've heard there's one in CVID that is being published on prophylaxis for bronchiectasis and infection, but it works. And apparently that's the take-home of that study that is apparently soon to be published.
There's a lot of questions. I'll try to group them into, there's some of them that are more high yield. Several people asked similar questions. One of the questions is nasal sprays. They're an alternative to nasal steroid sprays. They cause severe nosebleeds when I use them. And what's a good nasal spray that does not cause a nosebleed? Very good question. As I mentioned, nasal steroid sprays are really important in the management of primarily chronic but also acute sinusitis. All nasal sprays are not the same. There are some of them that cause more nosebleeds than others, and there's such a big variety of nasal sprays. Some of them are milder than others. So first, I think it is worth trying some other nasal sprays that are, so for example, there's nasal sprays that are that deliver a very, very fine mist. There's a prescription one that is called Vera Mist. Now it's over the counter. It's called Flonase Sensi Mist. It's very different. You kind of hold it this way and you spray up your nose. There's nasal spray that are made of powder. There's a couple, one called Zaytuna, but it's more of like almost like an inhaler. It delivers more a powder as opposed to a liquid. There's a new one that's called Exhance that's you put in your nose and your mouth and you blow. So there's such a big variety. So definitely ask your immunologist about what other options can be used. Number two, using the saline rinses and moisturizing the nose well before you use the nasal spray can be very helpful in keeping the nose moist to reduce the chance that we'll bleed. And if absolutely all nasal sprays or nasal steroid sprays don't work for you, yes, there are some other options. There's nasal antihistamine sprays. It's like nasal Benadryl, for example. These are prescription medications, and these can also help reduce inflammation. So don't give up on the first nasal spray. I have to say Flonase, for example, is one of the older nasal sprays. It's more alcohol-based as opposed to liquid or aqueous-based, so it tends to cause more nosebleeds. But don't give up on one nasal spray. There's multiple other things that you can try.
Okay, someone asked about the link between complicated pneumonias and bad things like lactic acidosis and sepsis. There is a link. If you have complicated pneumonia, you're much more likely to have suffered one of those complications, septicemia. Another person asked, what about when do I get antibiotics? How do you determine if I have bronchiectasis, do I deserve antibiotics? If you're, to me, if you're having recurrent pulmonary infections or recurrent exacerbations of bronchiectasis, you deserve a trial of antibiotics. Typically, what's recommended is azithromycin. We get a culture, a sputum culture, to exclude mycobacterial infections and an EKG to look for a long QT. And if you make it through those screens, you get put on azithromycin.
Questions about a couple of questions about this nasal steam therapy, using steam therapy, and it helps with some people, and should we use it or is it bad? No, if it helps you, that's fine. One of the questions mentioned, should I be concerned about introducing any kind of infection? So the container that you use, you definitely want to make sure this is clean, does not have any mold buildup in it, and so on. I think it's okay to use that. It's okay to use regular saline spray like ocean spray. I do not think they will replace, however, the saline rinse. The flush that you get with this 8 ounce of saline rinse can really clean things very well and clean the mucus. So it's okay to use the others. I don't think they replace the full saline rinse.
Next question, how can you arrange for my immunologist to test for ILD? If they do a CT scan of the chest, they are checking for interstitial lung disease. The interstitial lung disease that occurs in common variable has a very characteristic set of features. It's almost like when you see a cat, you know it. Would you recommend antibiotics during times of expected respiratory illness? Yes, that's why we love seeing our patients over time. I have patients that do great in the summer. And they're like, I don't need to take prophylactic antibiotics, but all winter they have problems with either chronic sinus disease or other things. And under those circumstances, we put them on prophylactic antibiotics during the cold months, which in Wisconsin is every month, except for like 2 weeks.
To follow up on antibiotics, very similar question. I get sick, and every time I get a sinus infection after a cold, it progresses into eventually a bacterial infection. Should just treat it early on with an antibiotic and prevent all that. Like Dr. Rhinitis said as well, it depends on every person. But yes, if you're somebody who's every time you get a cold or a sinus infection, it's very hard to get rid of. you want to start antibiotics sooner rather than wait those 5 or 7 days or so. It varies a lot from patient to patient, but that's not a bad idea. And on a related note, why is Biaxin not recommended for sinus infections? So the Infectious Disease Society of America, a few years ago, they did this a very extensive review on what antibiotics work and don't work for sinus infections. The reason they put Biaxin, Z-Pak, and Bactrim on the list of not recommended for acute sinus infections is they found that the high rate of resistance of Streptococcus pneumoniae. So strep pneumoniae, one of the most common causes of sinus infection, there's a lot of resistance to these antibiotics. But it doesn't mean that they don't work. They can work, but I would rather not use them for an acute sinus infection, not take the risk that it's not going to work and 5 days later I'm going to change it. On a related note, they're not bad antibiotics. Dr. Cunningham-Rundles mentioned earlier today that azithromycin prophylactically can be used. I think these are good to use preventively, but if you're in the acute setting of an acute sinus infection, I'd rather use something that I'm more confident is going to work.
Can you have restrictive and obstructive lung disease? Yeah, it's pretty common to have both. And what happens when bronchiectasis reaches such a point where it interferes with your quality of life? There are times when you can have such severe bronchiectasis where you'll get recurrent pneumonias in a lobe that you'll actually have to remove that lobe. It's rare. I mean, I can count on one hand over 30 years where I've done that, but it can happen.
And these can be very quickly answered. Or is allergic seasonal allergies cause rhinosinusitis? Yes, allergic rhinitis, when it's not well controlled, can contribute to sinus infections by interfering with good drainage. We talked a little bit about that. Is secondhand smoke also a risk factor? Yes, as long as you're inhaling the smoke, then that's going to affect you. And a quick question, what is a concha bullosa, and can it be shown on a sinus CT? A concha bullosa is if you want, a swelling of one of the, what we call them the turbinate inside the nose. There are 3 turbinates inside the nose. If one of them has little air inside of it, it becomes bigger. It's a really benign thing. A lot of people have it incidentally on a sinus CT scan. It is shown on a sinus CT. It can contribute to problem by, if it's big enough, it will obstruct the normal drainage of the sinuses. In that case, something can be done about it, such as surgery.
Thank you again for all of your questions, and we apologize if we didn't get to your specific question. Please, again, let's give a round of applause to Dr. Azar and Dr. Rhinitis.